So before I begin, again, my salutations to my teachers, some of whom are in the audience and some of whom are not. This is going to be a most deglamorized presentation after the previous beautiful images that you have seen. But it's a little bit more practical. LMPCI, what role for physiology? These are my disclosures. We know that the angiogram is not always very accurate when we look at severity. And we know that FFR relates very well to long-term outcome as far as adverse cardiovascular events are concerned. We know that FFR guided PCI gives better outcome, that is if we use FFR to decide whether we need to or we do not need to address ischemic burden in this particular patient. And the concept of FFR guided revasc is based on well structured and consistent randomized controlled trial derived evidence and firm clinical outcome data. Now let's look at some post PCI FFR. Let's look at some cases. This is a 78-year-old female, non-diabetic, hypertensive dyslipidemia with crescendo angina for 4 weeks. She was all of 38 kgs in weight and 150 centimeters in height. This is what her angiogram was like. I'll just allow it to play out. This is just the left system that you can see. You can see a heavily calcified left main bifurcation with disease in the proximal, left anterior descending and the circumflex, as well as the circumflex and the left main, and this is what the RCA injection is like. So we had a discussion and both the surgeon and the patient didn't want to look at each other because the surgeon said she's too small and the patient said the surgeon is too big, the procedure is too big. So she was sent to us for a staged procedure. First we did the RCA. It was heavily calcified, proximal to distal, diffuse, eccentric. This is a rota plus a cutting balloon and an OPN. And you can see where we've used, this is a cutting balloon followed by a stent followed by an OPN to get good expansion, and that's what the RCA was like. So we've got good distal targets, but there's a lot of calcium in the proximal part, and we did rotablation to the LED. I've left the LCX wiring on purpose to show you how difficult and how tortuous this was. And the microcatheter wouldn't follow the wire, even once we had got the wire down. So we had to do a small balloon, then put the microcatheter, then put in the rota. The wire was stuck here, so we did it in bursts of 10 millimeters each. And finally, we were able to get the rotablation burr down all the way down to the distal circumflex. Thereafter, an OPN was used to open up the proximal segments, and a DK crush was done after a cutting balloon for the circumflex. This is our DK crush. I'm not going through all the steps. This is not part of what we want to show. And this is the first pot, the KISS, the second pot. This is our final result. Now, this is when we start doing our work. A post-PCI physiology is done, an FFR and RFR to the LED, 0.95 and an RFR of 0.95 with a pullback, which is not at all unsatisfactory to the LED, and the circumflex RFR is 1 with an FFR of 0.97 in the circumflex. The second case, a 72-year-old class 3 CCS class 3 angina, angiogram done outside, advised PTCA to the mid RCA and to the LED, and this is what the left disease is like. You can see a mid LED eccentric tubular lesion and some doubtful lesion in the proximal LED, which we really aren't able to make out. So the RCA was fixed, and then after that the left was worked on. So the plan was to do a mid LED PCI and then reevaluate the osteo LED. That's what was done. This is the mid LED being done. We'll not go through all the steps. I'm just quickly trying to go through so that we have some time for discussion at the end. This is a provisional, and a KISS pot is done for the LED and the diagonal. Now what about the osteo LED? So we float in an FFR wire and you see the RFR straight off baseline is 0.78. Now is this because of that osteo LED lesion or it's somewhere distal? So we then do an RFR pullback. And what do you find? You find that all the step up is actually at the osteo LED. So then the significant stenosis of the osteo LED and LM LED is done with a provisional strategy, and then we'll remeasure the physiology. That's what is done. We do a nice LM LED crossover stent, do a proper pot with an LM, do a pot, KISS and a repot, and then do a post PCI FFR and RFR, and we get a 0.91 in the LED and an RFR of 9.7. Remember, this was 7.8 in the beginning. This is what our final angiogram was like, and she's absolutely fine, angina free at the end. This is the third case, a 72-year-old lady, again class 3 effort angina. She's got an ostial LED disease, and the disease seems to be extending into the mid LED as well. There's some distal LED disease, but nobody's going to touch that. It's about 50-60% with a bend, so it can most likely be left alone. The LED is pre-dilated, cut with a cutting balloon. There's some calcium there, but we get good expansion, so we decide not to do anything further. A stent is placed and then a pot is done. And this is what the angiogram is after the pot. The ostial circumflex looks a little hazy. Lots of people will say, let's leave it alone. We don't need to do anything. Patient is fine. There's no dissection. It's flowing TME3. But we decided to do a physiology. And you find that the RFR is 0.85 at the ostial circumflex. And the pullback, as you see, the arrow is just at the ostial circumflex. So a pot kiss and a repot is done. And then we measure the RFR back again. And you get a 9.8 and a 9.92 measurements. And then we also remeasure the LED because we have disturbed the stent in the LED. So we want to know whether the LED has been given a good enough result. And that's what happens. We find that the FFR to the LED is 0.97. This is our final angiogram. This is another case. This is just to show you that this benefit is not restricted to chronic stable angina alone. This is a 62-year-old patient, dyslipidemic hypertensive, comes with an anterowall MI with post-MI angina, day 1 Phillips class 2. He's got ongoing chest discomfort, and we can all see that there is a subtotal occlusion in the mid-LED with a large diagonal coming off, and he undergoes a fairly straightforward angioplasty to that segment. A nice post-dilatation is done. This is the result. And if you noticed in the initial angiogram, there was also some doubtful disease in the circumflex. If we can get this to play, right. So this patient was part of a study that we were doing in which we had a hypothesis that we were undersizing the stents when we did them in the primary, and we would bring them back to the table whenever they had an intermediate lesion in the other vessels. We didn't measure physiology at the acute situation because we weren't sure whether it was reliable. So we'd bring them back to the table, do an imaging to see whether we've appropriately sized the stent in the infarct-related vessel, and measure the physiology in the other vessels to see what kind of a result we got. So he was brought back to the table after about a week for an OCT assessment for the size of the LED. This is what it looks like. First, the OM, FFR and RFR to the OM were done, which were negative. As expected, it looks like a 60% lesion. We measured both because this was part of our study. Since we had the wire, we floated it down the LED, and we found that this RFR was positive, right? Now, FFR immediately after a week after MI, you would scratch your head and say, maybe not great, but a resting physiology sometimes throws up surprises. And when we did a putback, we found that the pullback was actually at the edge of the stent. So we went ahead and did an OCT, and you'll see when we run this OCT that there is a significant edge dissection where the previous stent had been placed. And I'm just going to run that repeatedly, and you can see that. This is what we got, a circumferential dissection at the distal edge of the stent. So we measured the landing zone, put in another stent, distal to the first stent, and then did an RFR again, and this time it's 9.7. And this is the FFR post first stent. This is also part of our study, was 9.2. And this is the OCT after the second stent has been placed, which looks absolutely fine. This is perfect. There's no problem at all. No edge dissection. We've got good expansion, etc., etc. This is our final angiographic result. Now, post-PCI FFR is one of the most underutilized tools in the cath lab. This is an old study from the bare metal stent era, and it shows us that the restenosis frequency, in those days, target vessel revascularization was measured 6 months after follow-up. When the FFR was 0.75 to 0.8 post-stenting was 29.5%. And when it was more than 0.96, restenosis frequency was 4.9. And this shows you the power of physiology in estimating whether we have done a good job in the vessels in which we are intervening or not. Post-PCI and FFR and prognosis, they are directly related to long-term events, as has been shown from large data. If you divide them into quartiles, patients who have the lowest post-PCI FFR consistently show a worse outcome. This is registry-based data, but what about interventional data? Prophet FFR was a study presented in EuroPCR 2022, wherein they looked at 1,300 patients, approximately divided them into 3 groups. One control, one group 1 who had at least one lesion with an angio-guided PCI, and the second group who had a post-PCI assessment that was driven by FFR, guided by FFR. And they looked at the second group, post-PCI improvement in FFR post-PCI. 12% required a further optimization based on the post-PCI FFR. And this group had a significant difference as far as target vessel revascularization is concerned and target vessel failure was concerned. This was reduced in the physiologically guided group versus the angio-guided group, almost halved. And there was no significant difference in MI and death, but target vessel revasc was half the rate when we used post-PCI FFR. Thus, it's an excellent marker of adequate relief of ischemia. The residual FFR is related to outcomes in several studies. This is possibly a stronger outcome than imaging, but it needs a little validation. The quality of the data is excellent, and that's what we are going to try to do. In summary, physiology today is meant for diagnosis, to rule in ischemia. Do we need to do the lesion or do we need to defer it? We have excellent data to suggest that we have the best answer to this question with physiology. Do we need to do more? The side branch FFR often tells us whether we have an ischemic burden in that area, not an atheroma burden, but an ischemic burden, which is absolutely well validated as an outcome measure. Have we done a complete job? The post-PCI FFR and RFR are powerful tools to answer this question. We are doing a small study called Pulmaris, in which all left main bifurcation angioplasties are subjected to post-PCI FFR into both. We're going to follow up and report. Watch this space. Next year, we'll have something for you. Thank you for your attention, and I've left some time.